very, very excited today to have Dr. Howard Frey, who is a urologist and the director of the Multidisciplinary Urological Oncology Center of the Valley Hospital, and he will be talking today about prostate cancer and your PSA. Welcome, Dr. Frey, and thank you for being with us today.
Thank you. Okay, so as Suzanne said, I'm the director of the Multidisciplinary Urologic Oncology Center at Valley Hospital, and what we do is see second opinions for urologic cancers. We also see patients who want further explanations concerning their cancer, what their choices are for treatment, and basically any questions that they may have. So this talk is going to be about PSA and how it's used to diagnose and treat prostate cancer. PSA being Prostate Specific Antigen. It's a blood test that is done often at this point. So what I want you to really make you cautious about is the internet. So I found this on the internet. Men with early prostate cancer can safely opt out of treatment. Occasionally this is true, but not always. So you have to be very, very careful in terms of what you're reading on the internet. You don't know where it's come from, what benefit it has to whoever put it on, etc. So I'm just cautioning, be careful. And you can see from this that prostate cancer certainly is a significant disease. Over here, it shows that there are approximately 270,000 cases of prostate cancer in 2022, which is, very comparable to breast cancer. And most people would not say breast cancer is a benign disease. And similarly, down here, prostate cancer was the second leading cause of death from cancer in men, with about 35,000 deaths in 2022, second to lung cancer. And again, pretty comparable to breast cancer, which also was the second leading cause of death in women from cancer after lung cancer. So what is PSA? It stands for Prostate Specific Antigen. It's a protein. What is its purpose? Its purpose is to liquefy semen in men. It says specific, although it's not really specific to prostate, although prostate certainly makes a lot of PSA. So since the PSA era, meaning since PSA was widely used to screen for prostate cancer, the mortality from prostate cancer has dropped significantly, about 40%. I mean, this is really amazing. A drop in 40% in any cancer is truly astounding. So, and this is a drop in mortality, or how many men die from prostate cancer. So it's really significant. And the other thing is that you can see a huge drop in men presenting with metastatic prostate cancer or spread of prostate cancer at presentation, drop of about 75% since PSA has been utilized for screening. I mean, this is really remarkable. And, in contradistinction to women using mammography, where there's not that much of a change in presentation with metastatic disease. So again, this is really astounding from PSA screening. Now, despite those things, the U.S. Preventative Services Task Force, a governmental agency, recommended that no man should have PSA for screening. I mean, it's kind of astounding. So why did they say that? Because they were using a flawed U.S. study on screening, where there was a large amount of contamination. What does that mean? It means that if somebody in this screened group had an elevated PSA, they would just drop out of the study and they would get treated elsewhere. So there was no real accurate follow-up of this, and the contamination was greater than 50%. So this makes it a very poor study. So what did the U.S. Preventative Services Task Force do? They gave PSA screening a D rating, meaning no man should have a PSA for screening. And what was the result of that? The American Academy of Family Physicians recommended no PSA screening for prostate cancer, no digital rectal exam for prostate cancer screening. So men, this is the result from a man's perspective. No PSA, and especially no digital rectal exam, high five. So what happened after primary care no longer recommended PSA screening for prostate cancer? As you might expect, metastatic prostate cancer started to rise. And you can see M1 means metastatic to bone in prostate cancer, and it was going down, 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 down. And after that decree, metastatic prostate cancer started going up. And this is another way of saying that. So prior to that U.S. task force recommendation, metastatic prostate cancer was dropping by 0.4% every year. After that, it started going up 5.3% every year, a huge, huge difference. So there was another study in Europe, the Göteborg, Sweden study, and the task force did look at this, but they looked at it early on. And with prostate cancer, you often have to look over a long period of time to see changes. And what this study showed was that the prostate cancer mortality, or how many men died of prostate cancer, was reduced almost by half over 14 years by PSA screening. I mean, this is really a remarkable number, and yet it was kind of discounted by the U.S. task force. But I should say that the U.S. task force did recognize that some prostate cancer was not a cause of mortality in men. So could we distinguish that? How can we tell? Well, in autopsy studies, this one, for example, showed that, say, Black men in the age range of 70 to 79 who died of other causes besides prostate cancer, and if they had a complete autopsy, about 50% would have some prostate cancer that never caused them any problem in their lifetime. This was overwhelmingly low grade or non-aggressive type prostate cancer. So there was a take-home message that most urologists got from the U.S. Preventative Services Task Force, and that was to try to avoid overtreatment of this slow-growing, low-grade prostate cancer. And if you found an aggressive prostate cancer, you better treat it early when it's still curable. Can we tell the difference? Yes, we can tell the difference. And one of the things I'm trying to do is make PSA great again. So what happens if your screening PSA is elevated? Well, the first thing is don't panic. There are different reasons for having a PSA, and one elevation of your PSA can be because of your age. So the older you are, the higher your PSA is going to be. BPH, benign prostatic hypertrophy. The larger your prostate, the more elevated your PSA is going to be, because benign prostate also makes some PSA. We know about prostate cancer, prostatic inflammation or infection. So prostatitis, which is pretty common in men, an inflammation of the prostate, can also cause your PSA to be elevated. Perineal trauma. What that means, if you're a bicycle rider, you're going up and down on your prostate, and that causes some trauma, and that's going to raise your PSA as well. So I don't want to dwell too much on this. There are, ways of trying to clarify your PSA. So there's an age-adjusted PSA scale. So if you're older, that can go up to 5.4. If you're younger, it should be below 4. So PSA density, that takes into account the volume of your prostate, and that can be useful. The PSA velocity, how fast it's going up, and the percentage of free PSA. Free PSA means not bound to the total PSA, not bound to the protein. So if it's over 25%, that tends to be associated with benign disease. Anyway, I don't want to dwell too much on those specifics. But there are other tests as well. So if you have an elevated PSA and you're kind of hesitant to undergo a prostate biopsy, there's a 4K test. This is a blood test that looks at different forms of PSA in your blood. And what that's going to do, this is the 4K report. And for this patient, he was in the high risk group, which gave him a 35% chance of having an aggressive prostate cancer. So this patient certainly should have a biopsy. There's no question, because there is a great likelihood he may have an aggressive cancer, which you don't want to miss. And this is Select MDX. This is a urine test. I like this test a lot. It has a great negative predictive value. What does negative predictive value mean? It means if your test is negative, then they will say there's a 98% chance that you do not have an aggressive prostate cancer. And they will say you do not have a 99% chance of having a very aggressive prostate cancer. So that test is pretty reassuring if you're questioning whether you should undergo a prostate biopsy. What else do we have? Parametric MRI of the prostate. So this allows for the earlier identification of prostate cancer. It gives a target for a biopsy if it's present. Now, prior to parametric MRI, just standard MRI would not really, it was more of an anatomical test. And prostate cancer kind of grows between the cells, and therefore it doesn't change the configuration of what the prostate looks like. So the parametric MRI uses indirect ways of finding cancer. For example, it will look at how water diffuses through tissue. Now, that sounds peculiar, but you can imagine if there are more cells because of prostate cancer in a certain location in the prostate, more cells because of cancer, then water would diffuse more slowly through that. And so that's kind of what it looks indirectly. There are other ways of looking at it indirectly as well, but it's proven to be pretty good at finding cancers. So what else? The UroNav system, it's a software type system that allows you to take the results of the MRI and put it on the ultrasound, which is how the prostate biopsy is accomplished. So it actually gives you a target. And this is just schematic, what we're seeing with, this is a schematic drawing of the prostate with a low-grade prostate cancer in green, and this peach color is a high-grade prostate cancer. And what do we see on an ultrasound view? I mean, generally, we don't see anything suspicious. Generally, we see just the prostate and nothing else. This is the MRI view. We see these high-grade or aggressive prostate cancers as targets. We usually don't see the low-grade prostate cancer, which we're trying to avoid. So, ultrasound prostate biopsy, just ultrasound without the MRI, again, this is what we're going to see, nothing, generally. So the biopsy is kind of random. It does go in certain locations in the prostate. And here we would have missed the aggressive prostate cancer and maybe found a slow-growing prostate cancer. This is UroNav prostate biopsy, which uses the MRI. It's called a fusion biopsy because it takes the MRI and allows it to fuse it onto the ultrasound so we have a target. So what do we see? We don't see the slow growing prostate cancer, but we do see the aggressive targets. And so it's what kind of we want to do. We want to find these aggressive cancers and perhaps not see the slow growing cancers that tend not to cause any problems. And this is a live version of a prostate biopsy. And you can see in purple here, that's the prostate outline. And here's the target lesion with a bullseye in the center. This is it will be a 3D image. And here's the line, you can line up the biopsy needle and you're going to hit the target pretty much. And when you're done, you know that you've hit the target because you can get this image. You see that you've hit the target in here outlined this way. These are other random biopsies that go in certain locations in the prostate typically. And obviously they missed this target lesion and the cancer. So the radiologists now have a standardized way of reading these MRIs, and it ranges from 1 through 5. It's called a PIRAD system. 5 is read as highly suspicious that there's high grade or significant prostate cancer present. And if it's a grade 5, there's an 83% chance of finding clinically significant prostate cancer. If it's a grade 4, there's a 60% chance of finding a significant prostate cancer. If it's a grade 3, only a 12%. So a grade 1 or grade 2 is fairly reassuring. So let's say you undergo the biopsy and there's a cancer there. That's going to be given in a GLEASON number, a GLEASON score. GLEASON was the name of a pathologist who came up with this system. It is a complicated system. It's based on the histology of the prostate cancer, what it looks like under the microscope, and there's different patterns of the GLEASON score going from 1 through 5, and you add the predominant pattern with the secondary pattern. And it's usually predictive of aggressive prostate cancer, but it's a complicated system. It's very difficult to talk to patients about a GLEASON 3+4 or a GLEASON 4+3. So, and you can see here, this is a GLEASON score. There's a lot of verbiage here because it's a complicated system. So there is a new system called group 1 through 5, and that's much easier to understand. Group 1 is the least aggressive, the one that's the most normal looking, and group 5 is a highly aggressive prostate cancer. So clearly a group 5 is going to need treatment, otherwise that cancer is going to advance and likely cause mortality in the patient. And this is my this is my pattern, which I don't think anybody is taking up. So what happens if you have a Gleason 3 + 3 = 6, which is group 1? This is the least aggressive type of prostate cancer. The histology, it looks kind of like normal prostate in some ways. But we also look at the number of biopsy cores that were positive, how much cancer was in each of the biopsy cores. We assess the age of the patient. We assess the health of the patient in determining what we're going to do. And really, our job is to find the wolf in sheep's clothing, and there's the wolf. So we want to try to find if there's any aggressive elements in this Gleason 6 prostate cancer, this apparently slow growing prostate cancer, because we don't want to miss anything. And genomics allows us to do this. It allows us to kind of separate the indolent or very slow growing prostate cancers from the aggressive prostate cancers. So one such test is called Decipher test. It looks for RNA in the biopsy that was already done, and it looks for RNA that's associated with more aggressive prostate cancers. And you can see it will divide it into high risk, intermediate risk, or low risk prostate cancers. So if it's low risk and you have a Gleason 6 prostate cancer, a lot of the time you can avoid overtreatment by going into active surveillance. This is a 15-year study. There have been many studies now, and this showed only a 1.5 mortality from prostate cancer. Only 1.5% of patients died of prostate cancer that were in this group in 15 years. So, you know, there's much more likelihood of you dying of a cardiac reason than prostate cancer. So, you know, some people would like, you know, to be like this, quick nurse, hand me the nothing for active surveillance. But you may wish that this is how it works, but it doesn't. The key word here is active surveillance. Surveillance is the key word. So there's a protocol for active surveillance. The genomic testing of the biopsy should confirm that it's low risk. We've discussed that. That's like the Decipher test that we talked about. You should have a PSA every 4 to 6 months to make sure it's stable. You should have a rebiopsy within 6 to 12 months to confirm that really there was nothing that was missed. And you should have a multiparametric MRI prior to the rebiopsy. So what are the reasons for abandoning active surveillance and treating the cancer? Well, if the genomic test is high risk, that's for sure. How about a rising PSA? If it's consistently going up and we can't explain it, it makes us nervous. Let's say the repeat biopsy shows a more aggressive cancer. Instead of a group 1, it's now a group 3. That patient should be treated. And sometimes a patient will have general anxiety about the cancer diagnosis. And, they say, I'm looking for a month before the PSA. I'm really nervous about it. I'm fretting. I can't do anything. And just general anxiety, they say they want to get treated and have less worry about their cancer diagnosis. So sometimes they'll get treated. So let's say somebody has a GLEASON 8 or a group 4. This is an aggressive prostate cancer. And I don't know if you can remember, but this histology of the cancer looks much different than the GLEASON 6 or group 1. So if there's an aggressive prostate cancer, you're not going to get active surveillance. So you have to decide between surgery and radiation, basically. So here's the robot for a robotic radical retropubic prostatectomy. And this is the machinery for stereotactic body radiation therapy. So both of these are the newer ways of having surgery or radiation for prostate cancer. And you can see here, this is radical prostatectomy versus radiation therapy and cancer-specific survival. Patients that have had prostate cancer that was treated either with surgery or radiation. And you can see that the survival is about the same between radiation and surgery. Now, this is in contradistinction. In 1982, surgery looked a little better at 15 years, marginally better, a little better at 15 years. So because of that, there was a limit on the age when men would get surgery, and that limit was 70. That's because 70-year-old men could just potentially get to 85, but they didn't live past 85, according to the statistics and books. So generally speaking, 70 was the limit for prostate cancer. Now that has inched upward, but everything is much more similar now. The surgery has gotten better in terms of the technique, but the dose of radiation was increased because it can be much more confined to the prostate without hitting the bladder or the rectum. So the dose of radiation increased, and therefore the cure rate is better. And so this shows that with robotic surgery, most people now are going to get discharged same day or within 24 hours. So that's a big improvement in surgery technique. However, there's still risks of surgery. And here you can see that most patients with incontinence after surgery are going to be better, but about 6% will have persistent urinary incontinence, which is a bad problem if you're in that 6%. And erectile function recovers somewhat, but not back to normal in many patients. One reason is that patients generally are getting older when they have a radical prostatectomy, which is a time when their erections are not as good as before in general. I'm sure if we did this operation in 16-year-olds, they'd all have erections. So what happens with your PSA after radical prostatectomy? Well, you don't have a prostate anymore, so it should be undetectable. PSA is excellent for following prostate cancer after a radical prostatectomy. It should be undetectable. So if the PSA is not undetectable. If it's going up, there's something going on related to your prostate cancer. So what happened? You do an evaluation, your prostate PSA is elevated, it's not undetectable. You do an MRI or a CAT scan or a PSMA scan now. At any rate, you see here that there's local recurrence in the region where the prostate was after radical prostatectomy. So what do you do for that? You're going to do radiation after this with still a pretty good chance of cure. PSA is up after radical prostatectomy, and there's oligometastatic bone disease, meaning there's spread here to the ribs right there. After radical prostatectomy, that's the only place. This is actually bladder. This is not any spread at this locally at this point. So if there's local spread there, what are you going to do? You're going to do radiation to that area with still a fair chance of cure. So what about stereotactic body radiation, SBRT? It's an outpatient procedure, involved delivery of only 5 high-dose treatments of external radiation over a 2-week period. So this is much improved compared to previous radiation. And does it have any side effects? Yeah, potentially it can have bowel problems, urinary problems, erectile dysfunction, feeling of tiredness, lymphedema. But I would say in general, since SBRT, we're seeing much, much less radiation problems. And one reason is this SpaceOAR, which is a gel that is injected between the prostate and the rectum, and it separates the prostate from the rectum by several centimeters, which would be like 100 miles in radiation terms. So the rectum largely is spared from any radiation effects. And I don't like to say it, but I shouldn't say it, but I haven't really seen any rectal problems since SBRT and the SpaceOAR. And then there's also fiducials that are put in. These are the gold fiducials. These are put into the prostate. And so it identifies the prostate. And what this allows for is the SBRT machine to follow the prostate in real time. That means if you move slightly by accident, then the machine, the radiation machine, will follow the prostate movement and in real time correct the delivery of radiation so that it's much, much more accurate by giving all the radiation to the prostate, less to the surrounding structures. If there is PSA is up after radiation, there's a problem. Here, the PSA does drop after SBRT. It doesn't necessarily go down to undetectable as it would with radical prostatectomy, but it should be stable and low. So if the PSA is going up at some point after radiation, there's a problem. And let's say we find there's a local recurrence after radiation. Generally speaking, we wouldn't recommend a radical prostatectomy because there are many more potential side effects of doing a radical prostatectomy after radiation. But you could still do cryosurgery or freezing the prostate, and that's, I think, the niche for cryosurgery at this point. If there is oligometastatic disease after radiation, meaning there's one bone met, for example, bone metastasis, then you can do radiation to that solitary bone metastasis as you could after radical prostatectomy as well. So what happens if the PSA up and there is widespread bony metastases? after radical prostatectomy or SBRT. Well, this is a bone scan that does show significant bony metastases. All these dark areas would represent prostate cancer in the bone. So then you're going to get ADT or hormonal treatment, which is designed to lower the testosterone. And this is highly effective, although it may not last forever. But it was so effective that the only urologist ever to win a Nobel Prize, Charles Higgins, got it for discovering that lowering the testosterone would affect prostate cancer for the better. And this is a summary slide. You know, we start with the PSA, digital rectal exam. We may do other testing, and we may go to a fusion biopsy, fusion meaning an MRI, multi-parametric MRI first. And we would get a diagnosis of prostate cancer. We will do a decipher or a genomic test. At that point, depending on the GLEASON score, if the GLEASON score is low, we take into account the stage, the age, the health of the patient. And after all of that, we decide on treatment, whether to do active surveillance or to actively treat the prostate cancer. And after all that, the U.S. Preventative Services Task Force decided to give PSA screening, instead of a D rating, a C rating. So we're somewhat more happy about that. And again, we're the multidisciplinary urologic oncology center. If you have any questions about your disease, we can give you a second opinion or explain things better to you or more completely to you. We have more time. So we're capable of doing robotic prostatectomy, radiation, SBRT, active surveillance, hormonal treatment, chemotherapy if necessary, which we didn't discuss. We can recommend a biopsy or not, genomic studies, genetic studies, MRI, the prostate, bone scan, PSMA scan. So with that, I guess, any questions?
Thank you so much, Doctor. That was so comprehensive, and really appreciate your time. Just a couple questions. Somebody asked about these advanced tests taken following an elevated PSA. Do you know if they're typically covered by Medicare?
Some of the advanced tests, I mean, if you have a diagnosis of prostate cancer, I would say almost always they would be covered. I mean, I would have to think hard about somebody's specific, insurance, but almost always they would be covered. Yes.
Great. A couple of people have questions about the risk. Someone says, I have 100 cc volume homogeneous score. Could you tell me a general risk? If that's, what is my risk, I guess?
Say that, just repeat the question one more time, please.
Somebody just wrote, I have 100 cc volume homogeneous. Does that make sense? What is my risk?
Well, 100 cc prostate volume is huge. So that is one very big prostate. So, I mean, so if you told any urologist that your prostate volume is 100 cc's, that's going to mean, well, two things. One is that you expect the PSA to be high, just on the basis of the large size of your prostate, the volume, and the high volume that's making more PSA is going to give a higher PSA value. So it's also would make it a little bit more difficult. It would make it, not a little bit, but it would make it more difficult to do an accurate biopsy because the size of the prostate is so big. Now, fortunately now, there is multi-parametric MRI of the prostate, which would potentially show that there is a targetable lesion within this large volume prostate. So it becomes much more specific and not random. So I hope that answers the question.
Great. Someone is asking, can you talk about stage 4 cancer?
Well, stage 4 means it's metastatic. So typically metastatic to the bone. Prostate tends to, if it's going to advance, it tends to advance to the lymph nodes and or bone. So if there's limited metastatic disease, meaning it's in oligometastatic disease, meaning it's in one or maybe two bony locations, then potentially you can treat that with radiation with success. If there's a large amount of metastatic disease, as was shown in the last slide, then typically somebody is going to get treated with hormonal treatment, possibly with chemotherapy, and all of this is dependent on their health, their age, their kidney function. So, you know, it is a little bit complex, but generally somebody's going to be treated by lowering their testosterone. Now, in the past, that was with standard medications such as Lupron. There are some others as well, but nowadays, additional medication that will drop the testosterone even further is available, and that has been shown to prolong survival. So, and there are constant updates and improvements to these regimens. If somebody has stage 4, you know, we would recommend genetic testing, which is a blood test to see if there's an abnormal gene, because if there is an abnormal gene, such as the BRCA1 or 2 gene, then there is medication that works about 80–85% of the time if that gene is abnormal. So, you know, these are things that I really haven't mentioned in here, but which are available. So that's a separate talk on stage 4 prostate cancer.
Thank you. Do you recommend surgery or versus radiation generally, or does it depend upon an individual?
Well, I try to, it definitely depends on the individual. I mean, some patients are going to say, whatever it is, I want it out. So in general, they're going to get pushed a little bit more or directed more to surgery. And some patients are going to say, whatever it is, I'm not going to have surgery. So they're going to get radiation. But that's the simplistic answer. The more complicated answer is it depends on a lot of other factors, such as their general health, their age. If they're not healthy and they've had a lot of medical problems, they've had a heart attack and a stroke, then they're probably not going to have surgery. And, you know, they may have radiation or, you know, hormonal treatment. So it's a much more complicated question than meets the eye. It used to be an easy answer, but it's no longer an easy answer because the results of radiation and surgery are approximately the same. You know, the results are the same. The prostate specific mortality is approximately the same. There are different risks for surgery and radiation. If the patient is older, it's more likely we're going to recommend radiation. You know, there's still a little bit, although without proof at this point, there's a little bit of feeling that if the patient is very young, he's, let's say, in the 50s, that one study way back in 1982 showed that surgery was slightly better at 15 years, well, maybe that patient's going to more likely have surgery recommended. But it's almost an individual choice. One is not grossly better than the other. Some urologists feel that if somebody has a very, very aggressive prostate cancer, that maybe the best thing is throw the kitchen sink at it, meaning do surgery, maybe radiation afterwards, and hopefully that will cure the cancer. So there is no quick and easy answer to that question. It's a very individualized recommendation. And in fact, that is why often we see patients in the multidisciplinary urologic oncology center, because they're confused and they want further explanation about what to do. And we try our best to explain their options, the pros and cons. Sometimes it's easier for us to recommend one thing over the other. Sometimes, they're equal.
Thank you. Another question is, which is more indicative of a potential for prostate cancer? A PSA total score or a percentage free PSA? Does that make sense?
Well, I mean, typically somebody's going to get the total PSA first. Percent free may be, slightly more indicative of a cancer. In other words, if the percentage of free PSA is 25% or greater, we're a little bit less worried about it, the PSA. If the percent free PSA is 6% or 7%, we're more worried about it. But it doesn't always correlate. I should say that. It doesn't always correlate. It's just another indication that perhaps we should be looking and not ignoring it, a PSA. So, because a lot of times a PSA is slightly elevated, and, a lot of times we'll monitor that, and, if it's going up, then we're more concerned about it. And the other gentleman had a very big volume prostate. We take that in consideration, because you tell anybody that there's 100 cubic centimeter prostate, well, that's going to have that person's going to have an elevated PSA for sure.
Just a couple more questions, if that's okay. At what age is an age-adjusted PSA used? I don't know if you mentioned that.
Well, there are different scales. So, for example, if somebody is in their 40s, up to 2.4, 2.8 would be considered normal, but over that, not normal. So, so we're more concerned if somebody's PSA is high when they're young. If somebody is older, we're expecting them to have a larger volume prostate, and therefore we expect their PSA to be higher. So, but we also look at the change in PSA. We're more concerned if there are larger changes, incremental changes in PSA. So if somebody had a PSA of 3.8 and suddenly it was 6.5, that gets our attention. On the other hand, somebody else could have had a PSA of 6.4 for the last 5 years, and now it's 6.5. That's not, even though it's the same number, it's probably not as significant. So, there are a lot of, that's the difficulty of PSA. Normal prostate also makes normal PSA, and therefore it's not the greatest test, but it does give us some insight into when we should do a biopsy or not do a biopsy.
Okay, so, and just one last question. Would you be able, what is a normal PSA for, say, a 76-year-old man who's a bike rider with BPH?
Well, again, it depends a little bit what his PSA was. I mean, we often encourage, to be off the bike at least a week or 10 days, before getting a PSA test. It's hard to give an absolute number. I mean, if you use 76 is starting to get up there where we're not as focused on looking for prostate cancer. We still often do, and especially if there's a change in that PSA, it's getting larger and it's jumping higher. The velocity is bigger. And if the patient is it sounds like a bicycle rider, is in good health, then, we're concerned, so if somebody is 76 and is in good health, I mean, that has one implication. If somebody is 76 and is, had a stroke, their longevity is probably not going to be the same. And so you have to take that into consideration on how aggressive you are in looking for prostate cancer. I mean, that's a key. And so it's hard to give hard and fast rules about that. Everybody's situation is going to be different.
Of course. Well, thank you so much, Dr. Frey. This was wonderful. We really appreciate your time. I'm sure we all enjoyed this great